A very good morning and welcome to our course on refractive surgery toolbox. What all do we need to become successful refractive surgeons? So at the outset, I would like to thank AIOC for giving us this opportunity, second time to conduct this course in a row. And last year we received a very good feedback about our course, and hence we thought of conducting this course on the similar pattern as the previous year. And we have retained the same talks and the same course faculty. So essentially the course is about newer diagnostic technologies for refractive surgery evaluation. So since refractive surgery is such a dynamic field and every few months a new equipment or machine is introduced with the purpose of improving preoperative patient selection or treatment planning. However, it is important for us as clinicians to understand the principles behind these machines, how they work, what are their capabilities, and how we can use these machines to the best of their capabilities and for the for our patients. So with this background, we will commence the course now. It's my pleasure to invite our first speaker, Dr. Sheetal Mahawakar. She is a well-known cornea, cataract and refractive surgeon from Ahmedabad with excellent surgical skills and great clinical acumen. She's currently working as a medical director at SM Eye Institute, and she's a visiting consultant in the cataract and cornea and refractive department at Retina Foundation, Ahmedabad. And she'll be sharing her tips on reading topography for refractive surgery evaluation, a very basic yet one of the most important topics in refractive surgery. So, Sheetal, all yours.
Yeah. So, how does this get connected? A very good morning. I think yeah. So, at the outset, I would like to thank my dear friend SHEETAL BRAR for including me in her course. So, I'm going to talk about the topography per se. So let's start why it is important to do a good evaluation before any refractive surgery. So this gentleman, 38-year-old, had come to our clinic with decreased vision. He had given the history of LASIK done some 7-8 years back, and his preoperative refraction was -1 with 0.75 and -1 with -1 cylinder in the left eye. Not a great preoperative refractive error. His current refraction is -1 at 60 and 6.9 vision. Left eye, his vision is 6.6, but he's not very happy with it. What he showed me was a piece of paper in which written was pre-op Paki and these keratometry readings, although there was no topography. So when I did his topography, this is a frank keratoconus LASIK ectasia in right eye, and there is a subtle cone in the left eye, subtle ectasia in the left eye also. So that's the reason why it is important to do a thorough evaluation and read your topographies well, because the incidence of post LASIK ectasia, which is true even for smile, that you do get post smile ectasias also, is still there. So it is important for us to know whether our patient is eligible or not. So I will just skip this slide and we'll jump on to the topography. So before going into this, what is topography and what is tomography? So basically topography is something like a 2D image where Placido disc is used, and it depends on the principle of reflecting these images of Placido rings on the cornea. So basically we are studying the anterior corneal surface and tear film out here. Vis-a-vis tomography is something like a 3D corneal image where you are studying anterior, posterior curvature of the cornea, anterior surface, posterior surface, and whatever is there in between and little bit behind it. So the ones which we use are nowadays, OpScan is almost kind of, I would say, obsolete. So the ones which we use is the Shimflux based, which is Pentacam, and the other ones which are used by most of us is Ceres and Galileo, which is Shimflux plus Placido disc based. And something which is even superior than this tomography is OCT based tomographies. So as we can see, there are multiple scans and cross-sectional images in Shimflux as well as OCT. In Placido disc, it is just a single shot. So as I said, that it is important to know the posterior surface, because sometimes what happens is whenever there is an early cone or early ectasias, the epithelial will mask these early cones. So we need to see, because a lot of changes happen at the posterior side first. So it is very important for us to know the posterior surface. So what we are going to talk about is essentially tomography and not topography. So if you look at this map, this is what we generally get it on any pentacam or cirrus map. This is a pentacam map, which are the four. We get a curvature map, which you can go and change it into sagittal, tangential, or posterior, whatever you want. There are anterior, posterior elevation, and there is a global packet thickness. Now curvature map is, there are axial map and there is tangential. Axial will give you a overall pattern of the cornea, so it will kind of differentiate it from normal to abnormal, and tangential will give you slightly more detail, so it might give you a pattern of the disease. So one needs to know on curvature map what we need to see. There are different types of topography maps, like a round and oval comes to normal, but the rest all and the symmetric bow tie is normal. Rest all inferior steepening, asymmetric bow tie, symmetric bow tie but with a skewing like this map is abnormal, and we need to take care of it. So the red flags by pentacam, they have some values which are given to us. Is one is inferior irregular steepening, anterior elevation more than 12 microns, posterior elevation more than 17 microns, and a thinnest point which is slightly away. Plus all these 4 points should coincide with each other. It should be that where your steepening is, your anterior and posterior elevation should be there, and your thinnest point also should be there. It cannot be that thinnest point is somewhere else and your steepening is somewhere else. That means it is not ectasia or keratoconus you're dealing with, and you need to get into the detail. Now, whenever we are talking about tomography, we need to understand what is the concept of a reference surface. Mind you, every reference surface for every cornea is measured for that particular cornea. So it is basically a reference surface is measured from your own cornea, and this concept has come from a terrain topography where the sea level is the reference surface. So we also need some kind of a reference surface for us to compare that what is steeper and what is flatter. So a machine kind of will take all your corneal points into consideration and have a reference surface, although there is no consensus which reference surface is better. By default, pentacam uses the sphere one, the cirrus will use the toric spheroid ones. So it depends. You can go and change and actually can learn a lot by changing all these things onto the machine and play with your machine and decide. So pentacam also has BAD-D, which uses enhanced best fit sphere. So now what is enhanced best fit sphere? As I said, a normal best fit sphere, it is measured from your 9mm cornea. All the points are considered. So if your cornea is steep, your reference surface will also be steeper. If your cornea is flatter, your reference point will be flatter. So what is the principle behind enhanced BFS is, what it does is basically it will exclude the points 4mm from the thinnest point. So this is, if this is your thinnest point, you just draw a circle which is 4mm around the thinnest point, where if you have a keratoconus, your steepest points will be there, and that it excludes. So basically the steepest points will be excluded, so the resultant enhanced reference surface will be flatter. Now how is it useful is, if you put this flatter surface slightly on an early cone, your early cone will get accentuated. But if you don't use the enhanced best fit sphere, because your reference surface is steep, maybe you will miss out on the early cones. Because your normal cornea will not have this very steep and very flat point, even the enhanced best fit sphere will be something very similar to a normal best fit sphere in a normal cornea. So this is what everyone is very used to. The BAD-D display is, the first two are with your normal best fit sphere, second ones are with your enhanced best fit sphere, and third one is difference between the two. So basically it helps us to evaluate the early cones. Now on the right side, there is a pachymetry session which you have seen that there is CTSP PTI. Basically what it means is, it gives us, there are concentric rings, 22 rings, which are drawn from the thinnest point towards the periphery. So it basically tells us how a pachymetry is behaving from the thinnest point towards the periphery. So if in keratoconus, it will be the thinnest point and the periphery is normal, so it will go below your normal standard. Is exactly opposite in something like a Fuchs endothelial dystrophy, where your cornea is edematous, so your center is also edematous and thick. So the difference in the center, that thinnest point or whatever it is, to the periphery is not so much. So the graph will go superiorly. So that is how you can even pick up early Fuchs endothelial dystrophy on topography and maybe avoid doing refractive surgeries in such cases. Now you must have come across all these Ds. They are different, this thing. The one which I like is the dy, which is displacement of the thinnest point, and the main D is not a parameter but it's just a regression analysis. So you give little bit importance because it is just analysis from whatever normative data machine has it is from the Caucasian eyes mainly, so just don't go on that. Asymmetric indices, I will avoid it right now for the time purpose, but there are a lot of asymmetric indices. The more important one is the superior inferior asymmetry indices, which are important. Now we all must be used to these particular maps also. These are Cirrus maps. They look different because the color maps are slightly different, so colors look different, but essentially if you start reading it, they are very, very similar to what we have discussed, where you have your global Pachy, you have curvature maps. The curvature maps in Cirrus are better because it uses Placido for the curvature maps, and for the elevation it uses the Schimflug images. They have a keratoconus screening where they use the symmetry index of front and back. Basically it gives us a vertical asymmetry. It will give you the highest point of the ectasias on front and back, and BCVF and BCVB, basically what machine considers it is your cone starts at inferior temporal region, so it basically will manifest a lot of coma, trefoil and spherical aberrations. So these three things they'll consider, and they'll give you in your kerato summary whether it is a normal, suspect or a frank keratoconus. There's something which I really like in Cirrus's keratoconus summary. If you look at this last image, which is black and white, is the same thing. What they are showing is all the points. So if you are dealing with an ectasia, all those points like your thinnest Pachy, anterior elevation, everything will congregate together. If these points are scattered, that means you're not dealing with something like a keratoconus or ectasia. So there are a lot of things which even the Cirrus machine gives. It also gives us the CTSP and the PTI charts. So this is a topography where if you see it, the curvature maps look fine, the anterior elevation map looks fine, but there's a subtle cone in the posterior elevation which we would have missed in a normal topography. But if you do tomography, you can pick up and avoid a refractive surgery in such a case. Now if you look at this particular case, elevation maps as well as curvature maps look normal, but what is little abnormal is if you look at the pachymetry map, there is a lot of displacement of the thinnest point. So that is again a red flag for us to observe this thing, whether it is normal or whether it is progressing into ectasia, and maybe avoid it. And if it does not progress it, maybe go ahead with a surface ablation or something like that. Again, this is a case where the curvature and anterior elevation is normal, but if you see the posterior elevation, it shows the posterior elevation which matches with your thinnest point. So again, the other eye had a proper cone. So these are the cases which we can miss it on just a curvature topography or a Placido topography. This is again a case, this is a Cirrus map where you can see the inferior steepening, irregular bow tie, but the elevation looks normal. Curvature maps on Cirrus always gives you a pretty good picture. So in such a case, again, you should have the things. Lest all doesn't look very abnormal, but this is a patient of VKC and there is a history of rubbing. So you should observe such patients rather than going for refractive surgery, because you may land up in a problem. If you observe and things are not changing, if his VKC is controlled and now he doesn't have any rubbing problems, you may go ahead with surgery after observing him for a year or two, or maybe little more, and go with surface ablation. So there are a lot of things which will give us subtle clues. Like this particular patient, if you just go for the curvature map, it looks like an inferior steepening, but that is because basically this is a case, if you look at the pachymetry map, it's all thick. It is a Fuchs endothelial dystrophy case and not actually a cone. So there are a lot of things. If you look at the CTSP map, it is going up. So to summarize this, tomography is must for new age pre-refractive surgery evaluation. Curvature map, elevation maps and thinnest point should consider together and not separately. Posterior elevation and global package shows early changes, and bad D enhances subtle cones because of the enhanced reference surface. Thank you so much.
Thank you, Dr. Sheetal, for those excellent tips and pearls on reading different types of topography maps. So for the want of time, we will have the discussion towards the end of the session. So next speaker is me. Okay. So good morning, friends. I'll be discussing something about epithelial thickness profile and why it is important in refractive surgery. So let's know some facts about epithelium. So other than epithelium being a barrier to the external environment, along with the tear film, it also represents an optical interface and plays a critical role in the refractive power of the eye. Small changes in corneal epithelial thickness can cause significant refractive changes, and the refractive power of the epithelium itself ranges from 0.55 to 1.85 at a central 2 mm diameter zone. So, epithelium has power. This is something we always should remember. So, in normal corneas, the average central epithelial thickness is around 54 microns with a standard deviation of 4 to 5 microns. And Reinstein et al. Have demonstrated a non-uniform pattern of epithelial distribution wherein the superior and temporal corneas are thinner compared to inferior and nasal quadrants. So, as one word of caution, the epithelium is not a homogeneous depth over Bowman's layer. So it's not a homogeneous layer. What epithelium tries to do is that it compensates for the underlying stromal irregularities, wherein it becomes thick over the valleys and thin over the hills wherever the stroma protrudes. So basically, it attempts to minimize the abrupt changes in the stromal thickness. So the anterior cornea may appear smoother on topography, as Dr. Sheetal also showed in some of her examples. So it is important to study the epithelium separately. So assessment based only on topography with no knowledge of epithelium may sometimes be misleading. So essentially we have ASOCT and ARC scan, which is very high frequency ultrasound, two main modalities to measure epithelium. So ASOCT is based on the spectral domain OCT, wherein 24 radial scan lines with a scan depth of 2 millimeters are used to generate a color coded thickness map of the cornea, whereas the ARC scan utilizes a 50 to 100 megahertz ultrasound system. So OCT is a non-invasive and non-contact method, whereas the ARC scan is an immersion-based method that needs special medium and topical anesthetics. So OCT is less operator dependent, and ARC scan has high operator dependency. Repeatability and accuracy is thought to be better for OCT, whereas it can sometimes suffer due to corneal compression or decentered positioning of the probe with the ARC scan. And tear film is included in the measurement when OCT measures epithelial thickness, and it's not included with the ARC scan. So coming to differences between different OCT machines for epithelial thickness measurements. So right now we have the OptoView, the Cirrus 5000 and MS39 from CSU Italia. So for the OptoView and Cirrus, you need a cornea external lens, whereas this is not required for MS39. The resolution in tissue is best for MS39, this 3.8 microns in tissue. For OptoView, it is 9.9, and for Cirrus 5000, it is 12.5. The area measured is again widest for the MS39, 16 millimeters, versus 6 millimeters in OptoView and 9 millimeters with the Cirrus 5000. Now, coming to clinical applications of epithelial thickness profile study. The most important application, I would say, is screening for ectasia risk in refractive surgery candidates. So as we all know, corneal thinning is a hallmark of ectatic corneal diseases, and if you look at the histology, basically it looks like in an area in ectasia, a localized zone of epithelial thinning over the steep area surrounded by an annulus of thickened epithelium, which is classically referred to as epithelial donut pattern. So here we have a case of keratoconus, 26-year-old female, and you can see that this is a frank case of keratoconus, and there's this bulge here on the anterior curvature map, and correspondingly, if you look at the epithelial map, which is the central one, the lower figure. So here you can see that the blue zone is denoted by a very thin epithelium, and around this thin epithelium you have a donut shaped pattern of a thickened epithelium. Now, this is a classical donut pattern which you see in keratoconus cases. Now, not that every time you will have such clear cut cases. So many times we come across suspect topography, wherein you can just have few features of a suspicious cornea, but it may not be a keratoconus. So these are the cases where epithelial thickness will actually help you in making the picture more clear. So such as in this case here, if you see, there's some amount of inferior superior asymmetry and posterior elevation observed on pentacam. When you repeat the scan with MS39 for this patient, you can also see on the epithelial map there, the right upper image. So there is there is a epithelial thinning. So there's a thin area which is also surrounded by a thickened area. So it's an early donut pattern which is starting. And what is most important here in MS39 is that it also gives you stromal elevation map. So you must also look at the stromal elevation map, wherein you can see that corresponding to the area of ectasia, there is also about 9 to 10 microns of elevation of the stroma. So in this way, epithelial thickness can also help us to enhance the specificity and avoid false positive cases, because many times we see that at pentacam there's a over diagnosis of keratoconus. So these cases can actually be ruled out by using by studying epithelial thickness profile. Also planning refractive surgery procedures such as transepithelial photo refractive keratectomy, which is the trans PRK, and PTK procedures. So you must keep into account the vertical variability in mapping of different zones, and this is also important to maintain accurate refractive results and avoid creating unintended corneal abrasions. So epithelial thickness is also important to study refractive regression after refractive surgery. So as expected, if you treat higher amounts of refractive errors, you can expect more epithelial changes, and this can help us to differentiate the various reasons why somebody can have a power after surgery. So we did a study basically to see epithelial changes post smile, and we found that in low myopic group there was a 6.83% of epithelial thickness increase in the center. In the moderate myopia, it was 9.27%, and in high myopia, it was as high as 12.7%. So this also can actually help you decide your nomogram. So if you see that at 3 months or 6 months you're having lot of epithelial changes, so you can also look at revising your nomogram. So this also helps us to differentiate between regression and undercorrection seen in the postoperative period. So again, another very important indication is to differentiate between early ectasia versus regression. So because this is so important, if you misdiagnose a ectasia and treat it like regression and treat the patient with a laser second time, it's going to make the condition worse. So like these are two cases. You can see both cases are post smile. The first one is post smile. 6 months later, patient develops slight power -1 with 0.75, improving to 6/6. And on the right side, this patient is smile 3 years prior smile was done, and patient has a similar type of power. But if you look at the scans of both the eyes, the epithelial scans, you can see that the pattern is completely different. In the first map, there is a central thickening, and in the right map, there is a central thinning, and this is being surrounded by a early donut pattern. So on the left side, what you're seeing is a thickened epithelium due to regression, and on the right side is basically early ectasia. So it can also help you differentiate between myopic and hyperopic ablations. So many times we come across LASIK patients who have come for cataract surgery opinion, and they do not have any history or any reports available. So when you do a topography, then you will actually you sometimes are not able to make out whether it's a myopic ablation or hyperopic ablation, because if it was a low refractive error, then the epithelial changes would have masked the picture to some extent. But when you do epithelial mapping of these cases, it makes the picture more clear. It can also be used to plan enhancements, especially after smile. If you want to do a thin flap LASIK for smile enhancement, it is an indispensable tool, because you want to know the epithelial thickness before performing the correction, and this is basically to avoid creating a too superficial flap that may enter into the previous interface. So to conclude, knowledge of epithelial thickness profile is especially beneficial in close call judgments, clinical judgments. It's a newer modality that newer modalities combining epithelial profile and stromal elevation maps like MS39, as I said, enable a more confident decision making by ruling out false positive cases of suspect keratoconus before refractive surgery. So in this way, it is a quite a indispensable tool, and nowadays we are seeing epithelial profile for all our patients before planning the type of procedure even for them, and also in cases with contact lens users. So in these cases also, epithelium can sometimes give a very different kind of picture. So you can ask them to stop the contact lenses and then repeat the epithelial scanning and then take a proper decision. Thank you so much for your attention. Dr. Supriya Sri Ganesh, a wonderful colleague and a young and dynamic phaco-refractive surgeon, currently working as a consultant in Netradhama Super Speciality Eye Hospital, Bangalore. At a young age, she has some prestigious international awards, best papers, best film awards at ASCRS to her credit, and she has been making us proud at various international forums. So, thank you, Dr. Supriya, for joining us. Today, she's going to speak on the role of abrasions in decision making in refractive surgery. Again, a very important topic.
Thank you, Dr. Sheetal, for that kind introduction, and thank you for including me in your IC. I would like to thank AIOS for this opportunity as well. So today I'm going to be talking about abrasions and why we need to care about them. Let's see. Presentation is open. Can we start off with the next speaker? It's connected. Yeah, can we try and set it up? That's it.
Check.
Meanwhile, they're fixing the presentation for Dr. Supriya. I think we can go ahead with the next presentation. Dr. Raghavendra, are you ready? You can go to the...
Which?
Raghavendra, can you start on the other side? So I'm very glad to invite Dr. Raghavendra Reddy Ara, who is currently working as a phaco and refractive consultant at Vision Eye Hospital in Hyderabad. So Dr. Raghavendra did his long-term fellowship in cataract and refractive surgery from Netradham Eye Hospital in 2018. And while he was in his fellowship, he worked on some prestigious research projects and publications with us, and also presented papers at ESCRS and won awards at Karnataka and Telangana Ophthalmic Society for his scientific films. He'll be touching upon another very important topic from patients' eligibility point of view for refractive surgery, which is corneal biomechanics. And he'll be talking about role of corneal biomechanics in preoperative refractive surgery planning.
Yeah, good morning, everyone. Thank you, Dr. Sheetal, for the kind introduction. So, corneal biomechanics is the study of biomechanical properties of cornea. Cornea exhibits properties of both viscosity and elasticity, and all viscoelastic materials exhibit hysteresis, which is a differential response seen during loading and unloading. And in terms of cornea, it is the ability of cornea to absorb and dissipate energy. And this behavior is a dynamic one. Any eye that is at risk of developing ectasia usually goes through various phases before landing up in ectasia. Initially, there are changes in elasticity, followed by biomechanical changes, then topographical changes, and then the changes that you pick up on slit lamp. In a routine standard of care, a patient who's planning a refractive surgery undergoes evaluation using topography and the study of aberrations, and then we plan the refractive surgery. But in very small subset of patients, there is a chance of developing post refractive surgery, post laser vision correction ectasia, and these patients might require C3R, and that might become a problematic thing. So with the incorporation of corneal biomechanics in routine evaluation, you can segregate the patients based on the corneal biomechanics and then customize your laser vision correction so that you can avoid the complication of post-LASIK ectasias. So there are various ways of measuring the corneal biomechanics, and the common feasible ones are using the ocular response analyzer and Corvis ST, which I will be speaking in detail. There are various corneal biomechanical properties that have been proved with ex vivo testing. That is, cornea exhibits a progressive stiffening when there is a high strain applied, and the peripheral and paracentral cornea are paracentral cornea is stiffer compared to the central cornea, and cornea stiffens as we age. And this is a landmark study where it was found that the anterior 40% of the corneal stroma is stronger than the posterior 60%. Ocular response analyzer was the first device that was commercially available to study the corneal biomechanics, where a puff of air was projected onto the cornea and the bidirectional applanation process was then studied, during which various measurements can be obtained. However, this has few limitations. Studying the ocular response analyzer slope alone is not adequate to study the corneal biomechanics in detail, and the corneal resistance factor is dependent on the corneal thickness, which can affect the final results. Brilon optical microscopy is a new technique by which we can study the biomechanics, wherein it is based on the principle of Brilon scatter. When there is when there is an interaction of incident light on acoustic photons in transparent media, there is shift in the frequency of the incident light, and this shift in the frequency can be measured using a spectrometer. Following this, the frequency shift can be converted into elastic modulus using the indence density factor, and thereby we can know the elastic modulus of that material. So this is the image of a bovine cornea, the Brilon image, where you can see the anterior cornea is stronger and it has higher elastic modulus compared to the posterior cornea. Coming to Corvis ST, which is an advanced form of non-contact tonometer, which also includes a Steinflug camera. During the bidirectional corneal applanation process, the cornea goes through various phases. That is, the first applanation, highest concavity, second applanation, and back to its original position. And during this phase, the Steinflug camera captures the images, and then the anterior and posterior corneal borders are delineated. And from these, the various parameters are then obtained using the inbuilt software. So of the various displays that we have with Corvus, the first one is the DCR display, that is the dynamic corneal response display. Here you have various dynamic corneal parameters that are measured, such as the deformation amplitude, corneal apex velocity, the applanation length, arc length, and other parameters. So a cornea which is soft has a higher deformation amplitude ratio and a higher integrated radius, whereas the stiffness parameter A1 and the ARTH is lower. And these values are vice versa for cornea which is stiffer. So if you can look at the corneal deformation response, in a normal cornea there is an ingoing phase, first applanation, you have the highest concavity, and then this is followed by the outgoing phase. So the second video is a comparative video between keratoconus and a normal cornea. You can see the highly compliant cornea with more undulations and more deformation. And this compliance is even more when you look at a cornea which is a keratoglobus one. So this deformation response is a comparative video between the pre-op and post C3R procedure for a keratoconic eye. You can see that the cornea is more stable and the oscillations or the undulations are little less. So Vincingvera screening report is a kind of a screening report that you see in bad display of pentacam. Here on the top you can see various parameters that are plotted against time, and on the bottom you have a very important index called as the stress strain index, which is the measure of the corneal stiffness. So one advantage with SSI is that it doesn't get influenced with the cornea, with the corneal thickness or the IOP. However, there is a positive significant correlation with age. The second important parameter is the Corvus biomechanical index. This is an index that is obtained by linear regression analysis of 4 important corneal dynamic parameters, that is the deformation amplitude ratio, the integrated radius, ARTH, and the stiffness parameter. So CBI more than 0.5 is considered to be abnormal. The third display is the ARV display, that is Ambrosio Roberts Vincingvera display, wherein the data obtained from the Corvus is combined with the data from the pentacam to get something called as a tomographic biomechanical index. So you combine the tomographic data and the biomechanical data to get this value, and TBI more than 0.3 is considered to be abnormal. An important parameter which is highly sensitive and specific that is obtained in this display is the CBI LVC, that is post laser vision correction. Here you can assess the biomechanical stability of the cornea after the laser surgery, and this also estimates the risk of ectasia in post laser correction patients. The fourth display is the new display that has been introduced, that is the BEST display. Here you can monitor the biomechanical changes over time, and in order to obtain this display you should have a baseline measurement, and this can be used for post LVC eyes, where you can see whether the patient's risk of ectasia after laser vision correction is there or not. So let's look at few case scenarios. This is a patient who has come for a refractive surgery opinion, and this is a subjective refraction. When you look at the 4-map refractive, everything looks within normal limits, and this is a bad display which is again within normal limits. And the corneal biomechanical parameters are also within normal. The CBI is 0.04 and TBI is also within normal. So in this patient you can safely plan any laser vision correction such as LASIK or SMILE, and this patient was advised SMILE procedure. Coming to the second scenario, here the patient has come for a refractive surgery opinion, and the subjective refraction is as follows. And when you look at the pentacam, apart from the corneal thickness, rest everything looks normal, and even the bad display also looks within normal limits. But when you look at the biomechanical parameters, the CBI is high, which is almost around 0.7, and the TBI is also higher, which is 0.3. So this indicates the cornea is biomechanically weak. So in these patients, planning a LASIK or a SMILE procedure would cause more harm to the patient than good. So this patient was advised SMILE extra in order to compensate for the biomechanically weak cornea. To conclude, corneal biomechanics is useful in screening the patients for refractive surgery, and it helps in it helps us in selecting the appropriate procedure. And you can also monitor the biomechanical stability of the cornea over long term, especially after any laser vision correction. And you can also see the progression and also verify the success of cross-linking after cross-linking in keratoconus size. And it also helps in screening for glaucoma in a normal tension glaucoma patients. Thank you.
Thank you, Dr. Raghavendra, for providing such useful insights into such a complex topic, and you have nicely explained the concepts and also great examples you showed with easy language. I think it was easy for all of us to follow. So we now move on to Dr. Supriya's talk.
Apologies for the technical difficulties. I hope it's working now. Good morning, everyone. My name is Supriya Sri Ganesh, and today I'll be talking about aberrations and why do we need to care about them. So before we discuss aberrations, what is a wavefront? This is a concept that we all wonder about, and what exactly is a wavefront? So if you take a surface with all the points of the light waves being in phase, that surface is essentially known as a wavefront. So when light passes through our eye, if it is a perfect optical system, then it comes out as a perfect wavefront. But our eyes are not perfect optical systems. They come out with aberrations. So what are aberrations? When light passes through our eye, some rays get deflected by the structures in our eyes, by the optical media. So these deflections of those rays are essentially called aberrations. Now, what you see in this picture is an example of a spherical aberration. Here you see the peripheral rays are getting focused a little more in front, whereas the central rays are getting focused further behind. So this is known as a spherical aberration. These aberrations are represented in the form of Zernike polynomials. It's just a mathematical representation of the aberrations. Now, when we talk about aberrations, there are a certain standard terms that we use, and let's get into that. The first one is root mean squared. So root mean squared in microns is a measure of the deviation of an actual image from the ideal image. So the RMS of an ideal optical system, a perfect optical system, is 0. It's only a quantitative value of the total aberrations. Then we have point spread function. So you can see that it's a representation of the retinal image, and you can see the various types of spherical aberrations and how the point spread function of each one looks like. You can see that spherical aberration looks like the light spread in the form of a halo. Coma looks like a comet-shaped spherical aberration. Trefoil looks like this typical Mercedes-Benz sign. Then we talk about Q value. Q value is nothing but asphericity. It represents the change in curvature of an ellipsoid surface from the center towards the periphery. So it's nothing but the shape of the surface. The average Q value of the normal cornea is minus 0.26, and it's just a measure of shape, so it does not have any units. So what actually gives rise to these aberrations? The reasons can be anatomical, for example, the tear film dryness, anything in the cornea, the pupil lens, etc., etc. Anything in the optical media can lead to aberrations. Refractive errors lead to higher order aberrations. The refractive errors are lower order aberrations, but refractive errors can also lead to higher order aberrations. Accommodation can lead to aberrations, as well as age. So all of these factors give rise to aberrations. Now, how do we measure aberrations? There are various aberrometers which are available in the market. In our practice, we have the iTrace and the VASCA. We will be talking about the scans of the iTrace today. Okay. The question is, do we really need an aberrometer in our refractive practice? So what are some of the indications for aberrometry? One of the main indications is to determine the source of aberrations. Where the abnormality is it in the cornea, is it more internal, and how much of the total aberration is there in the eye? This helps in decision making for refractive surgery, as we'll see case by case in the coming few slides. And post both cataract and refractive surgery unhappy patients, if the vision is 6/6 but the patient is still complaining about some kind of photic phenomenon, some kind of visual disturbances or discomfort, then abrometry tells you where that discomfort is coming from. Refractive lensectomies and dysfunctional lens syndrome, also to decide whether to do a presbyopic correction on the cornea or a refractive lens exchange, whether to see if there's any abnormalities in the lens, also for accommodation and contrast sensitivity. So I've always been taught that the decision making in refractive surgery is the most important part of refractive surgery. We all have these questions in our day-to-day practice, whether to do a corneal procedure or whether to do an ICL, whether to perform LASIK or SMILE, whether to advise the patient a topography-linked LASIK or a wavefront guided treatment, a wavefront optimized treatment or a wavefront guided treatment. Can I put a premium IOL in this patient? Should I do presbyopic LASIK for this patient or perform a refractive lens exchange? So all of these questions can be answered by all of the tests that have been spoken to you about by everyone on this panel, but only looking at abrometry. We'll have to do all of the other tests, including the complete clinical examination, topography, etc. But just looking at the abrometry maps, let's look at what kind of information the abrometry can give us to make our decisions in refractive surgery. Now, this is an eye trace map. This is a normal eye. Basically, 256 points are taken. This eye trace map is the wavefront verification display. It shows you the retinal spot pattern on the left-hand bottom corner. So the normal eye, it shows a fairly regular retinal spot pattern, and the higher order aberrations are minimal. It also shows you the auto refraction and the multi-zone refraction. Okay, this is an example of an irregular eye where you see the retinal spot pattern is completely irregular with a much higher order aberrations, 1.032. So let's look at some of these maps. So this map is a wavefront and corneal thickness summary display. So basically, the eye trace tells you the total aberrations in the eye or the total RMS value. It also splits it into how much of that aberration is coming from the internal optics and how much of those aberrations are coming from the cornea. So now if you look at this patient, and on the right hand side, it also gives you the tracy refraction and a few other parameters. It splits the higher order aberrations into various different types of aberrations like spherical aberration, coma, etc. So here you see that this patient has some astigmatism, but the higher order aberrations are fairly low. So would you advise LASIK or SMILE for this patient? If this patient, according to the topography and all your other clinical examination, is suitable for either LASIK or SMILE. So here the concept is that in SMILE, there is no cosine effect which is produced by LASIK, and also because of the shape of the lenticule, the studies have found that the amount of higher order aberrations induced by SMILE itself is lower. So SMILE may be a better option for this particular patient. Let's look at this post-SMILE patient. You can see in this wavefront comparison display of eye trace, basically what you're seeing here on the left side is the pre-dilatation map, and then in the center you're seeing after dilatation what was the aberrations, and on the right hand side is the difference map. So you see that post-SMILE, this patient comes back to you with a refraction of -2 with 0.5 cylinder, and after dilatation that refraction goes down to almost minimal. So what this shows us is that this patient has a spasm of accommodation, which you can actually make out by an eye trace map. So if the patient has a spasm of accommodation post-SMILE, it's very interesting that if you treat them with cycloplegics, it can reduce the amount of aberrations and the refraction comes back to normal. So this is how with accommodation the eye trace maps are seen. Now if you look at this map, again this is a wavefront and corneal thickness summary display. corneal topography summary display. On the left hand side, you see the left hand top corner, you see the total internal abrasions, whereas in the bottom corner you see the abrasions coming from the cornea, and in the middle you see the total abrasions of the eye. So in this patient you see that most of the abrasions are coming from internally, that's from the lens. So in such a patient, do you advise them a topography linked or wavefront guided treatment? First of all, we know that it's not on the cornea. The issue isn't on the cornea, it's something internal. So we have to dilate this patient and make sure that we do a complete lens examination, make sure there is no lenticular opacities, there's no subluxation, etc. So if we do that, we know that these abrasions are coming mainly from lenticular astigmatism. So if we only do a topography linked treatment, it only treats the corneal surface, and the patient is still left with those internal abrasions, and they will not be happy post the LASIK surgery. So it would be better to do a wavefront guided treatment for this patient. Similarly, if you want to see whether to do a wavefront optimized or wavefront guided treatment, we'll have to see the total abrasions of the eye. Here you see a visual function analysis display, which is basically the abrasions of the left and right eye. And you can see that this patient has a lot of blur. Can I take 2 more minutes? Yeah. Blur and double vision. So a wavefront guided treatment would be better than an optimized treatment in a cornea with higher corneal abrasions. Similarly, in this is a map. This is something called a Chang analysis. It shows you graphs with the abrasions. Here also you see that the internal abrasions contribute mainly to the total abrasions. You would want to do a wavefront guided treatment for this. So when you're looking at whether to do a corneal procedure or ICL, here you see that the corneal higher order abrasions are very high, and when the refraction is more than -6 or higher, you want to decide whether a corneal procedure or ICL would be better. Now you have to look at whether these corneal abrasions are because of a corneal scar or keratoconus, etc. And if it's so, it's better to do an ICL for this patient. And if the corneal abrasions are just because of an irregular cornea with high amount of higher order abrasions, then you can go for a corneal procedure. There is also a map called the DLI, which is a very important feature of the eye trace. Here you see anything below 5 shows you a dysfunctional lens. So you would rather do a refractive lens exchange or just a cataract surgery for this patient rather than a Presby LASIK or a Press Beyond. I'm just going to go ahead 2 more slides. In multifocal patients, you can see that this eye trace also has a display for angle alpha. So angle alpha is basically the angle between the optical axis and the visual axis. So in patients with a high angle alpha, if you put in a multifocal lens, it centers to the optical axis and not the visual axis. So the patient is seeing through the rings instead of the center of the lens, and hence they are very uncomfortable and get a lot of higher order abrasions. So before choosing premium IOLs, it is useful to do abrometry. So just a take-home message, with low higher order abrasions, patients are suitable for either SMILE or wavefront optimized LASIK. Significant higher order abrasions caused, if the total higher order abrasions are more, we can go more in favor of wavefront guided treatments. If the corneal higher order abrasions are high, you can go for topography linked treatments. And in significant higher order abrasions with high refractive errors, ICL may be more suitable. Always check the DLI before presbyopic corrections and check angle alpha before implanting premium IOLs. Thank you very much.
Thank you, Dr. Supriya, for explaining such a complicated topic with all your great examples and making it easy for us to understand. So it's my pleasure to invite the next speaker, another brilliant ex-alumnus of Netragama, Dr. Karthik Sriprakash, who is currently a consultant, phaco and refractive surgery at Sri Eye Care, Bangalore. And apart from being very hard-working fellow, which he was, he's also very creative. And during his fellowship, he made some great scientific films that won awards at ASCRS, and he also won
best paper of the award at AIOC 2018. And today he'll be discussing with us the role of optical quality analyzer, basically for assessing post-op patients' visual quality after refractive surgery.
Thank you for the warm words, ma'am. Always a pleasure. So we've all had this patient after a seemingly uneventful refractive surgery, and you've measured the vision, it's 20/20, but the patient is still unhappy. We've all had that patient. So what exactly is happening? Well, this is the time when we have to start looking at the role of optical quality in refractive surgery. Now, optical quality essentially has two main determinants. The first including aberrations and defocus, that was explained by Dr. Supriya very well. And the second is ocular scatter. Now, there are main areas for ocular scatter and post-refractive surgery eyes, and this scatter leads to retinal stray light. Now, the retinal stray light, it deteriorates the point spread function of the retina in the periphery and leads to these kind of untoward complications and untoward side effects. Now, the HD analyzer is an optical quality assessment system which objectively measures optical quality, and it takes into consideration the effect of aberrations and the loss of ocular transparency. Now, it has its advantages over traditional aberrometers, wherein these traditional aberrometers, they tend to overestimate the potential visual acuity. The HD analyzer uses a double pass system, and this analyzes the retinal image from a point source of light. Now, the first pass is from a 780 nanometer single point source of light laser diode, which goes through a Badal system with a focus corrector which corrects for spherical defocus. The second pass is from the retinal image, which passes through an artificial pupil, which is PA2, into a charge-coupled camera device, which is the double pass image. Now, there is also a camera which measures the natural pupillary diameter, and the artificial pupillary diameter can be changed anywhere from 2 millimeters to 7 millimeters, but the machine would take the smaller of the two diameters as the effective pupillary diameter. Now, the double pass retinal intensity PSF image which is obtained is analyzed to give three parameters. The first is the objective scatter index, which is, or the OSI. Now, this is nothing but the objective evaluation of the intraocular scattered light, and the way it's calculated is by calculating the amount of light which is outside the point spread function as compared to the amount of light at the center. A higher value would indicate higher scattering, and the normal OSI of a normal eye would be less than 1. The second is the modulation transfer function, which evaluates the degree of detail that can be distinguished by an optical system, in this case RI, and mathematically it is derived by dividing the contrast of the optical system or the eye by the contrast of the real scene. Maximal allowed MTF is 1, which would mean a perfect optical system. We also know that the contrast reduces as the spatial frequency increases, as we are able to see in the middle diagram there. And at a certain frequency, the contrast becomes 0 or close to 0, and this is called as the MTF cutoff. Now, this MTF cutoff is essentially the highest spatial frequency the eye can detect, and a higher MTF cutoff value would equate to a higher quality of the optical system. The normal eye has a MTF cutoff of about 60 cycles per degree. The third objective parameter is the Strel ratio, which is the ratio between the peak intensity from the PSF of an aberrated eye versus the peak intensity from a non-aberrated eye. A higher value would indicate a better optical quality, and a normal Strel ratio is about 0.3. So the steps of optical quality acquisition is that the first step is we need to determine the manifest refraction, and we need to confirm it to 0.12 diopters. Next, the pupils are dilated so that we can artificially control the diameter through the artificial pupillary aperture. And for optical quality assessment, the ideal artificial pupil diameter should be about 4 millimeters. After we enter the demographic data into the machine, we also enter the manifest refraction, and the machine searches for the best corrected spherical refraction around the determined range, and it can correct anywhere from +5 to -8 diopters, as well as cylinders of less than 0.5 diopters. Anything more than that, it would recommend corrective lenses automatically. The first sequence is the best focus sequence, which is necessary to avoid the blurring of the double pass image, and it's always determined before any other measurement. This searches for the best double pass PSF image by sweeping for different spherical diffractions to correct focus. And it also automatically selects this image, which is considered in most focus, with the corresponding refraction displayed below it. The second is the OSI measurement, and this is measured at the best corrected focus and with a artificial pupil of 4 millimeters. 6 double passed images with the best spherical correction are obtained, and green markings indicate that the machine considers that the image quality is good. Once the OSI is captured, the next screen would give you the image view area, which is what we see here, which is basically a convolution of the PSF image with the original image of the scene. It's basically what we see here is a image of a baby at one distance. It basically simulates a daily scene, which represents the effect of aberrations and light diffusion as how the patient is actually seeing. Although it doesn't consider glare and halos, but still it's a very good representation of how the patient is supposed to see versus how the patient is actually seeing. It also displays the OSI numerically and in a color-coded screen, and it also displays the potential visual acuity as we can see it in the right lower corner. The second objective is the MTF display, which can either be displayed in a linear or a logarithmic scale. It also displays the MTF cutoff as well as the strain ratio. The last thing that the HT analyzer can also do is also check our tear film analysis, wherein it captures 40 images at 0.5 second interval with a artificial pupil of 7 millimeters instead of the traditional 4. The point spread function image degradation over time is noted, and even blinks can also be noted, and the degradation the time is started from the time of the last blink. So this gives us a change in objective scatter index with time, which also plots the visual quality index. A newer software update of the HT analyzer also provides the visual breakup time, which is a very important indicator to see how much the dry eye is affecting the vision. Let's look at a few clinical examples. These are routine cases. The first one is a patient who's undergone relax smile uneventful surgery. We're just looking at the evolution of right eye with time. Preoperatively, the OSI is about 0.5 diopters, and postoperatively on day 1, the OSI is 0.4, and about 1 month later, it's about 0.3. Let's look at another case post-PRK. So preoperatively, the OSI is 0.3 in the left eye, and as expected on the 5th postoperative day, there's a significant increase in the OSI with a deterioration in the optical quality. The OSI has gradually settled down by the 15th postoperative day, and by 12th month, it's absolutely normal. Here's another case of an uneventful LASIK. Preoperatively, OSI is 0.3. Postoperatively, at 5th day, the OSI is 1, which is still okay, but it has taken some time to come back to 0.5 at the 1 month follow-up. Let's look at one interesting case where the HT analyzer helped us make a decision to start treatment early. So we had a 35-year-old female who was planned for relax smile in both her eyes. The manifest diffraction corrected to with the manifest diffraction, her corrected distance visual acuity in both the eyes was 20/16. Preoperative OSI in the right and left eye was 0.3 and 0.5 respectively. On the postoperative day 1, the patient was seeing 20/20, but she complained of some mild blurring of vision in both the eyes. The vision did not correct beyond 20/20 in both the eyes, and on slit lamp examination, some mild interface haze was noted. The anterior segment OCT was inconclusive, so we just repeated the HT analyzer, and we found that the OSI had significantly increased. Almost it's on the yellow. So what we did is we stepped up the topical steroids and we asked her to review after 3 days. 3 days later, she says that her blurring of vision has, she feels much better. And corrected distance visual acuity is now 20/16 parts. The interface looks clearer, and the OSI is improved significantly. So we asked her to continue her steroids and then taper it and then review after a month. After a month, she is absolutely happy, and even the OSI is settled. The unaided distance visual acuity is 20/16, and the interface was clear. So we've asked her to continue her post-operative medications as per her chart. So to conclude, the optical quality analysis system is becoming more and more indispensable in the era of very fine refractive surgery. It helps us detect any kind of deteriorating optical quality very early, as we saw in the previous case. It also helps us understand any pre-existing scatter preoperatively. It also helps us evaluate dry eye assessment, and it also gives us temporal data on follow-ups to understand how the scatter is deteriorating or improving. Since it gives us an objective understanding of optical quality without relying on subjective response, it ensures higher repeatability. And to make patients understand how different procedures would give different healing times, it would be a very valuable tool for patient counseling. Thank you so much.
Thank you, Dr. Karthik, for that very insightful talk on HD Analyzer and how it can be used for the benefit of our patients. So it's time now to invite the last speaker of the session. I know we all have been waiting for him to speak. He certainly doesn't need any introduction. Dr. Sri Ganesh is the chairman and medical director of Netradhama Group of Eye Hospitals, a prolific, frequent refractive surgeon, internationally renowned, a great mentor, teacher, and innovator who has always been on the forefronts of the technology and is a role model and favorite for people from all generations. Sir will be talking on a new latest ASOCT based tomography system, which is the MS39.
Can you bring up?
And its advantages in clinical practice.
Can you bring up my presentation? It's there. Good morning, dear friends, and I would like to thank Dr. Sheetal for inviting me to her course on the refractive toolbox, and it's very nice to be among my fellows, I think all of them whom I have trained over the years, and presenting in this IC. So I'll be talking about the anterior-segment OCT based tomography, which is the latest device, and what are the advantages in clinical practice. I am a consultant to Carl Zeiss Meditech and Biotech. So let's look at the technology. The OCT based tomographers are the most advanced devices for anterior segment analysis, and the MS39 combines a Placido disc corneal topography with a high resolution OCT based tomography. It delineates the epithelium from the total cornea and gives you epithelial maps, and you get a full coverage of the cornea. It gives you a 16 by 16 mm coverage. So even larger corneas, which are like 12.5 mm, you can get a good coverage, unlike other devices like the Pentacam, where you can just image 9 mm by 9 mm. So let's look at some of the applications. As you know, in refractive surgery, the most important application is to rule out patients who are not suitable for refractive surgery, and that is keratoconus screening. And this was a paper that looked at the accuracy of the indices of the MS39 for diagnosing keratoconus, and they found that it had a very high sensitivity and specificity of more than 97%. So it was able to diagnose keratoconus and also diagnose normal corneas. Now, if you look at the Pentacam, it has got a very low sensitivity. in the sense that the sensitivity is about 67%, especially if you're looking at the bad displays, but it's got a high specificity of around 97%. So basically the pentacam has a tendency to overdiagnose keratoconus if you're looking at bad. So even normal corneas, borderline or normal corneas can be classified as keratoconus in the screening, and so you will miss out about 30% of your patients. You'll be rejecting 30% of your patients for refractive surgery, and that is going to affect your income also. But it is very specific in the sense that if it says that there is no keratoconus, then 97% of the times you can be sure that there is no keratoconus, and you can go ahead safely with the refractive surgery. So in terms of safety, it is good, but then you will lose out on a lot of patients on whom you can perform the corneal refractive surgery. So with the OCT based system, both the sensitivity and specificity is very good. So that's why it is a very valuable equipment for diagnosing keratoconus and also for ruling out patients who are not suitable for refractive surgery. So if you look at the indices which are there, it has what are known as the notable points, which it takes into consideration, which is the epithelial thickness, the stromal thickness, the thickness of the cornea, the K-max, and the elevation. And it classifies it as normal, borderline, or keratoconus. Normal, the notable points total to more than 1, and 0.6 to 1 is borderline, and if it is less than 0.5, then it can be an indication that the cornea is abnormal and there can be keratoconus. It has also the other indices like the curvature indices, the elevation indices, corneal thickness, epithelial thickness, and you have a slider, colored slider. So if you look at the color slider and the indicator here, if it is green, that means it is normal. If it's yellow, it's borderline, and if it is red, that means it is abnormal. You also get like a warning triangle here if it is red, so you can know which parameter is abnormal. It also gives you a classification of whether the cornea is normal or keratoconus, and if there is keratoconus, it also gives you the keratoconus morphology, grading of the keratoconus, the ABCD grading, and also the phenotype, whether it's a nipple type, central, axial, or eccentric, and the keratoconus center, the axis of the keratoconus also. So coming to the Gaussian curve maps or the axial maps, they are more sensitive and true morphological picture of the pathology because it's got a placido disc typically, which is very accurate for curvature maps, and it gives the geometric mean of the maximum and minimum curvatures at one point on the surface. So here you get a keratoconus summary map where you have all the maps like the anterior surface, the posterior surface, the epithelial thickness, then the stromal thickness. So it subtracts the epithelium from the stroma and gives you the stromal thickness, and then the corneal total corneal thickness. It gives you the tangential anterior curvature, tangential posterior curvature, epithelial thickness, stromal thickness, again the pattern deviation, and the corneal thickness pattern deviation. It also gives you the anterior elevation and the posterior elevation, and of course all the indices. So in one screen you can get a lot of information. If you repeat the scans with time, you can also get what is known as the keratoconus progression in respect to all parameters like the anterior curvature, posterior curvature, anterior and posterior elevation, and the corneal thickness. And you can see the difference maps here. Over a period of time, if you're comparing two maps, you get the difference map, and which is color coded, and you can actually see whether there's a progression of the keratoconus. The epithelial map is very important nowadays for diagnosis of keratoconus, and I think Dr. Sheetal has covered this in detail, and this is a beautiful paper from Dan Reinstein where he shows that the epithelium has a masking effect, and It thins out over hills and it's thickened out over valleys, and it has a significant effect on corneal remodeling, and you get what is known as the donut sign in keratoconus. So it can be a very sensitive indicator of keratoconus when you look at the epithelial maps, because typically when you look at the pentacam, the teaching is that you have to look at the posterior elevation, and the posterior elevation is more sensitive. And there were even the theory that proposed that the keratoconus starts on the posterior surface of the cornea. Okay, but we know that is not true. In keratoconus, the pathology is in the Bowman's membrane, where there is thinning and fibrillation of the Bowman's membrane and bulging of the Bowman's membrane and the anterior stroma, and this is followed by the posterior curvature changes. But actually what happens is the epithelium kind of compensates for it. So because the epithelium is compensating for it, you don't see the anterior curvature changes early, and you see it more on the posterior curvature. But actually the keratoconus starts on the anterior surface. So when you look at an epithelial map, it is very sensitive and you can diagnose early keratoconus. So this was some examples. This is a 26-year-old female interested in refractive surgery. This is a refraction, a low myopia. And if you look at the pentacam, you can see that it shows a thin pachy, 458 microns, and the bad again is abnormal and shows that it is like a form frustrated keratoconus. And these are typical cases which you may reject for refractive surgery. You look at the bad and you say, no, patient is not suitable, and you can reject. But this is the MS39, which shows a thin pachy for 460 microns, but you look at the classification, it is normal. So what is abnormal here is only the thickness. So it is a normal thin cornea. And these are patients which are not susceptible for ectasia. So you can go ahead, and it's a low myopia. So you can go ahead and do PRK and the patient will do well. So this is another case, 26-year-old male interested in refractive surgery. Again, very low myopia with some amount of cylinder. And he's got a thick pachy. You can see that he's got a thick pachy, 561. But the bad shows a form frustrated keratoconus. If you look at the elevation map, both the anterior and posterior elevations, it shows an abnormality. Though the total score is normal, when you look at this anterior and posterior elevation, you are kind of confused and you don't know whether this patient is suitable, and you may reject this patient. But if you look at the MS39 and if you look at the parameters here, it says the classification is normal. Of course, the elevations are a little off. So sometimes in prolate corneas, you can get a higher elevation. It's not that the cornea is abnormal, but what you need to do is look at the epithelial thickness map. If you look at the epithelial thickness map, there is no donut pattern and the epithelium is perfectly normal. So this is a patient which you can go ahead and safely treat. It also has advanced analysis of the tear film. It's a non-contact assessment of the breakup time. And so with the Placido image here, you can actually look at the reflection and see if there is any abnormality in the tear film. It also gives you a breakup time and a map. So if it's all green, that means it's a normal breakup time. So this was a patient, an example, 25-year-old female who was using contact lenses for 5 years on and off. And this was her refraction, 4.25 with one cylinder. And if you look at her other parameters were normal, but if you look at the tear film, you can see the distortion here on the Placido rings, and you can see the breakup time is abnormal. Okay, both eyes. So then this patient was put on lubricants and then discontinued contact lenses, and you can see after 1 month the tear film becomes completely normal. But what you can also see is that the amount of astigmatism has reduced from 1.5 to 1, and the K reading also has changed. So a dry eye can cause problems in measurement of the K readings. So whether it is for refractive surgery or if you are doing biometry. So it's very important to measure the tear film and look at the breakup time. And this is a good device where you can do a non-invasive screening. It also gives you optical quality analysis summary. So it gives the wavefront and the point spread function. It also gives you a simulation of the visual function and the MTF. So by looking at this, you can know the optical quality of the eye. You can also look at individual corneal aberrations, and it also segregates the total from the epithelial aberrations. So you can look at the epithelial aberrations by itself, and you look at the total aberrations, and you can have an idea about the aberrations. It also gives you pupillography, so you don't need to have a separate device where it gives you the static pupillary offset and dynamic pupil, and it shows you the graph like this. So you can see that this is the scotopic 6.37, mesopic, and the photopic 3.73. So you can plan your optical zones when you are doing your surgery. It also can do what is known as dynamic vault assessment, and this is very useful in ICL cases. So I'll just show you how the vault. This is the ICL, and you can see as the pupil constricts, the vault keeps changing. Okay, so you can. We also did a very interesting study where we looked at different pupil sizes and the vault, and we saw that there can be a change, and it is different for different phakic IOLs with different materials, and it can also do advanced lens biometry, and it can give you the expected lens equator distance, lens thickness, predicted IOL position. For example, this is a patient with minus 14 diopters, minus 1.5. So you put in the data like the axial length, target refraction, pupil diameter, A constant of the implanted lens, and it will give you the power of the lens to be implanted. This is 10.5 diopters, and it will show you the optical quality also. So this is very useful. This is ray tracing. It also has a software for intrastromal rings where you can look at overlaying the rings depending upon the keratoconus. And it's got a very high resolution OCT of 3 microns. So you get a very nice OCT from limbus to limbus. This is intrastromal rings which are there in the cornea. So to conclude, the MS39 has multiple functions like keratoconus screening, enables anter-segment surgeons for better understanding of their patients' visual issues, and you can also choose the most appropriate treatment for them, and it's a very advanced tool. And I think this is all in one where you have multiple functions, so you don't have to subject the patient to multiple scans with different devices. So one device would do most of the give you most of the information that you need to plan your refractive surgery. Thank you very much for your attention.
Thank you very much, sir, for highlighting the role of newer OCT-based tomography systems. I'm sure there are many more applications. We just need to explore these machines more in detail. So, any quick questions from the audience? The speakers for the next session are already here.
We have 5 minutes, and they gave us the hall 5 minutes late, so actually we have 10 minutes. So if there are any questions, we can take a couple of questions on the various equipment, your refractive toolbox, all the devices which you require to do a good refractive surgery for assessing the patient. So any questions, any doubts?
I can see some seasoned refractive surgeons here, and I can see Rupal ma'am there. Ma'am, just if you could come.
Yeah, Tanvi is there at the mic. Hello, Tanvi.
Tanvi.
Thank you. I'm always very, I learn a lot from your talks. But one thing, you showed some topography scans which had the anterior posterior elevations shown where everything else looked okay. Do you give weightage to the white to white size, limbus to limbus, white to white? Because that's another
See, white to white is very important, and sometimes what you see is even some of the high myopes, the white to white is smaller. You expect larger corneas, but sometimes they are smaller, and typically they have steeper corneas. Now the K max in these corneas can be 46, 46.5, but they are normal, and typically they are more prolate. So you get this kind of increased anterior and posterior elevation. So it's not necessarily an indication that it is keratoconus, and if all the other parameters are normal, you can still go ahead and do the refractive surgery.
Any
I have done many
cutoffs?
cases like this, and they are
Do you
fine.
have any cutoffs for the white to white? Like less than 12 is what, even though you may see an anterior posterior elevation, you would still go ahead? Or is it, do you not have a cutoff? Like
No,
there's-
see, there's no definite correlation because sometimes, occasionally, you see this. Even higher myopes, typically you expect larger corneas, but the white to white is a little smaller and they are steeper. It's not in all cases, so there's no definite correlation. So you can't have like a cutoff as such, but you keep this in mind that sometimes you can have prolate corneas and steeper corneas, but still normal.
Thank you.
Wonderful session. I just wanted to ask two things. One is, if you have to buy only one instrument, one equipment, you think MS39 would be
Yes, I think
giving you most of the information that you would need?
The
in a refractive
MS39,
surgery?
I think, is more reliable. It's OCT based, and it also has a Placido. So the Placido is excellent for curvature maps and also for assessing dry eye and the surface. So this has both a Placido and an OCT. The OCT resolution also is 3 microns. So it is a high resolution OCT. So you can also use it for other things like assessing the flap, assessing the interface, which you cannot do with the Pentacam. And the sensitivity and specificity is actually much better than the Pentacam. The Pentacam overdiagnoses keratoconus. So that's why of course, Pentacam has become the gold standard for whatever reason, but these newer devices actually, I would say, are more reliable, and it gives you everything. It gives you white to white, it gives you the pupil size, it gives you tear film. So it gives you a lot more information, and it's a very fast scan. So you can get all your information just with one scan. So I think this is the way to go with time. Though it's much more expensive, I think it probably costs 3 times that of the Pentacam.
Also, do you find that if somebody has lens opacities, then your topography and tomography results are little skewed? So do you see the shadows of, especially in a dilated pupil, if you take topography or tomography, in a patient who has lens changes, do you find that you sometimes get more steepening seen or areas of irregularities seen in those opacified areas?
Basically the curvature maps are from the Placido disc. So the lens opacities have no influence on the Placido. And the elevation maps are from the OCT, ASOCT. And again, that has no bearing. See, the lens, you can image the lens, and where imaging the lens is important is for when you are doing your ICL calculations. If you want to look at the lens rise, it gives you the lens rise. And there are some formulae which uses lens rise in calculating vault for the phakic IOLs, and there it is useful. But as such, if there are lens opacities, in the MS39, you don't have like a densitometry like the Pentacam. The Pentacam has a densitometry where you can objectively look at the density of the nucleus and then kind of classify it and then correlate it with the log scores for cataract. The MS39 does not have a densitometry, but probably in future, looking at the reflectivity of the scans there, B-scan there, they can also look at lens densitometry. That's the only thing that it doesn't have, the densitometry, even corneal densitometry.
Thank you.
Thank you. Okay, conclude.
So with this, we will conclude the session, and I would like to thank all my wonderful course instructors and speakers for their excellent talks and discussion. And I would also want to thank all of you for participating in the session. And if you like the session, please give us a positive feedback so we are able to conduct this course next year as well. Thank you so much for your participation. Thank you.